This is wonderful. Thank you to everybody who's helped put this together today. This is really wonderful, and thank you for being here. I'm excited for the day. I think we've got just a list of wonderful speakers to be here. I'm going to start the day by talking a little bit about multidisciplinary clinics and the care that we provide for people with ALS, but also how we're trying to update that care and bring it into the 21st century and really sort of improve what we can do for people. I'm going to start with just a very brief overview of ALS and then talk about multidisciplinary care centers and then sort of end with a discussion of care innovation. I think to give an overview of ALS, the very first thing that we have to say is that this is a remarkable time for ALS. It's a time when we are discovering new genes very, very quickly at a pace that we've never experienced before. We have a newly approved drug to slow the progression of ALS. There are new innovations in how we can care for people that include telemedicine and restructuring our multidisciplinary clinics and growing them. There are new therapeutic targets, new sort of targets for us to test in trials, and we have new methodology for trials, running multiple drugs at the same time in a trial to bring efficiency and reduce placebos. And we have biomarkers, so for the first time we have imaging techniques to evaluate for ALS using PET ligands. And biofluid biomarkers in blood and spinal fluid, proteins that we can follow to see if our new therapies are making an effect on the disease. And finally, new technology that is touching everything that we do, from biomarkers, finding digital biomarkers of the disease, to augmentative communication and other assistive technology. And you'll hear about many of these exciting things going on today. But I think that's the first thing that we need to say when we give an overview of ALS, and that's a very different introduction to this disease than we had years ago. Now, ALS is a disease that affects the motor neurons, and there are two populations of motor neurons, the upper motor neurons, which reside in the brain, and the lower motor neurons that reside in the spinal cord. And the degeneration of these motor neurons, a hallmark of this disease, both the upper motor neurons and the lower motor neurons can cause weakness. But there are specific sort of different kinds of characteristics that come from upper motor neuron dysfunction or lower motor neuron dysfunction. And that causes variability from person to person with this disease. So some people have more upper motor neuron dysfunction and some have more lower motor neuron dysfunction, and that may lead to differences in the experience of symptoms throughout the course of the disease. Upper motor neuron symptoms are really the hallmark of them is sort of a stiffness, a slowness of movement. It can come out as imbalance and even muscle spasms. And when it affects what we call the bulbar region, which is a sort of a technical word for the mouth and throat, it can cause a slurred speech that's often sort of a tight kind of a speech, and increased gagging and even increased yawning, something that people sometimes ask about but rarely on their own would attribute to the disease. When we look on exam, we can find spasticity, and we can also find increased reflexes. And so the reflex exam is actually a very big part of our evaluation of upper motor neurons in people in whom we suspect ALS. And lower motor neuron symptoms, again, can cause weakness, but we see muscle thinning and cramping and twitching of the muscle. The fancy word for that is fasciculations. And we do see slurred speech as well, but it has a more nasal quality. And we see depressed reflexes. Now, we see a combination of upper and lower motor neuron symptoms in people who have ALS, but that combination can vary. And it's one of the sort of variabilities that can make the experience so different from one person to another. Another source of variability is the onset of weakness. So about a third of the time it begins in the bulbar region, again with speaking and swallowing, about a third of the time in the arms, about a third of the time in the legs. And very rarely, but not unheard of, is for it to begin with a respiratory problem, so the first symptom being some shortness of breath. When it begins in the limbs, it begins what we call asymmetrically. In other words, one side may be weak when the other side is not yet weak. And that is the sort of the typical thing that we see in the beginning. And that asymmetry can be mimicked by many other things, a pinched nerve, an injury to the limb, and so many people experience a long period of diagnosis when we're trying to understand what happened. There are other symptoms that can precede the weakness that we see, and I'll show you a list of those in just a minute. For the purposes of clinical studies and clinical trials, we take weakness as the onset of the disease. And we know that that is probably not the first thing that happens in the disease, but it gives us a very solid benchmark because the other symptoms can be a little protean and also highly variable in people. So fatigue is a part of the disease for most people, but to a largely varying degree. Weight loss is also a part of the disease, and again, to a varying degree. And we know that people who are losing weight rapidly have a more rapid disease progression. So this is something we talk about a lot in our multidisciplinary clinics, ways for people to maintain their weight. And this is not entirely related to having a difficult time chewing or swallowing. There are people who are chewing and swallowing perfectly fine and still have weight loss, and we really want to focus on trying to maintain weight because we think that that can slow the course of the disease. Pseudobulbar affect is a symptom where people have sort of easy laughing or easy crying, so much so that it can be actually socially sort of impairing. And there's a good medication to treat that symptom. We have to generally ask about it because it's not something that is automatically in a person with ALS's mind. If they don't know about the symptom, it's not automatically sort of tied to the disease. We think of ALS, we talk about ALS scientifically as a painless disease, but that's really not true because there can be pain from weakness, from immobility, or from an imbalance in the muscles that's pulling our joints in different ways and sort of adding to some discomfort. And that's something that we focus on a lot too. I'll talk in a minute about some of the things that physical therapists do in clinic to try to sort of ferret that out and treat it early so that we don't get too far down the line. Cognitive change. So about 5% of people who have ALS can develop what we call frontotemporal dementia. Now this is different than memory, just memory loss. This affects language and it affects behavior. And in those people who have this, it often occurs early in the disease course. It's often not something that shows up out of the blue later in the disease course. If we do very deep testing to understand people's pattern of cognition, we can actually find some abnormalities in up to 30% of people. But generally, those are not affecting day-to-day life. It is important in our understanding the biology of the disease, though. And interestingly, sensation remains intact in people with ALS, although we can see that there is dropout of sensory fibers. We see that in skin biopsies, and we can see that when we look at the sensory nerves themselves. There are about 2 to 4 new cases of ALS per 100,000 people per year. Now this number may actually rise because the average age of onset is around 58 years old, but it continues to go up as the population ages. So as we see an aging population, we may actually see more ALS because it's more common in those older categories. Over lifetime, men have a risk of about 1 in 350 of developing this disease, and women about 1 in 450. So it's an uncommon disease, but it's not a vanishingly rare disease. There is a male predominance. For every 3 men that get the disease, 2 women get the disease. And there is a part of ALS that is familial, that is inherited from one generation to another. And that is inherited generally in a dominant fashion. That is, half the people in any generation are affected, and it doesn't tend to skip generations. But this is a very complex area, and Dr. Brown is actually going to speak about this after I. This is a figure from one of his publications on the genetics of ALS, just from a few years ago. Here he highlights about 25 genes. At this point, we know that there are between 30 and 45 genes that we can say are causative of ALS. So we're discovering at an incredible pace. The one big circle there is a gene called C9orf72, and the second biggest circle is the first one down in the corner, the SOD1 gene. And this gene was discovered by Bob Brown in 1993. Really set us on a course for understanding this disease in a way that we never did before that. We have 2 approved treatments to slow the course of ALS. One is called Riluzole, the other is called Edaravone. The brand name for that is Radicava, and that was approved in 2017. So Riluzole is the first FDA-approved therapy. The initial trials showed that it slowed disease by 2 to 3 months. I think subsequent trials starting the drug earlier have shown more effect, and I think we would agree that there's at least about a 10% slowing of the disease from this drug. Not ideal, but and we hope for more, but it's a first crack at the disease. It's an oral tablet. It's taken twice a day, and there are newer formulations that are coming out. So there's a liquid formulation that's on the market now, and there's an oral dissolving tablet that's coming on the market soon. that oral dissolving tablet actually solves one of the issues with riluzole, which is you have to take it on an empty stomach, and that won't be true for the oral dissolving tablet. The most common side effect that we see with riluzole is nausea, and that happens in about 10% of people, at least initially. Many times we can get people through them. It's a smaller percentage of people who have persistent nausea and really can't tolerate the medication, but we do see that. Fatigue is listed as a side effect of this medication. I think because that's such a big part of this disease, it's hard to tell many times whether the fatigue is a part of the treatment or a part of the disease. And it can cause reversible injury to the liver, so we have to monitor what are called liver function tests. These are blood tests that we do once a month for 3 months after starting it, and then once every 3 months after that. Edaravone, or Radicava, is the next approved medication to slow the disease. The first large trial that was done with this drug did not show an effect, but if we looked in one subgroup, there was a much more marked effect than in some of the other subgroups. And it turns out this is people who are earlier in the disease and with a more rapid progression. And so the investigators took this observation and designed a second study that showed a 33% slowing of disease over 6 months in the next trial that was done. And so this drug was approved based on the evidence from really mostly the second trial, but the subgroup analysis of the first trial as well. This is an IV medication. It's given over 1 hour, and it's given in cycles. In the first cycle, 14 days in a row, and then 14 days off. And all subsequent cycles are 10 days out of the first 14. You can take the weekends off, and then 14 days off. The notable side effects, it's a very safe medication, very few side effects. If people have a sulfite allergy, that's different than a sulfa allergy. Sulfite allergy people mainly know about from having an allergy to red wine. Then we have to be a little cautious. It doesn't mean they can't take the drug, but we have to be cautious about it. Increased leg weakness is written into the label as a potential side effect. I think it's a little hard to know whether that is a part of the disease that showed up in an imbalance in the trial for some reason, or whether it's really a side effect of the medication. And because this is given IV, and because the easiest way to do that is to either put in a port, which goes under the skin, or what's called a peripherally inserted central catheter, which is like a very long peripheral IV, we have to manage potential infections of those lines. This has been not as big a problem as I had anticipated when the drug started, but we do see it periodically. There really is no monitoring that we have to do for this because it's an incredibly safe medication. Now those drugs are medical sort of crack at slowing the disease, and this is a remarkable advance from years ago when we didn't have either of these options, but they also occur in the setting of a multidisciplinary clinic. And the idea of multidisciplinary care is to take a person with ALS and surround them with all the resources that they need in the clinic so that I think the initial idea was really just so that we could cut down on the number of times that people had to come to the hospital. But over time, what we find is that these multidisciplinary clinics facilitate conversations on the treatment side, give people with ALS and their caregivers a sort of a medical home to go to, and organize the care between visits as well. And for that reason, it's been shown multiple times that they're associated with longer survival and with better quality of life. So I think this has really become a mainstay of care of ALS. I'm going to talk about a few of the specialties here. I'd talk about all of them, but in the interest of time, we'll focus on just a few and sort of how these specialties think about what they're doing in the clinic. So physical and occupational therapists are monitoring symptoms like walking and falls, activities of daily living like toileting and eating and getting in and out of bed, and then joint and muscle pain is another big thing that they're trying to prevent or treat if it occurs. They can evaluate function through examination as well as a history, and they can also do quantitative strength testing. And there are a few ways we can do that. They have acronyms, ATLAS, HHD, but these are just ways of getting a sense of how really quantitatively how strong our limbs. When it comes to interventions, there's a lot of bracing and canes and walkers if they're needed, but also strengthening exercises and stretching exercises and accessibility equipment to keep people doing the things that are important to them for a very long time. That's a fundamental part of what physical and occupational therapists are trying to do. Now, not all of these things are required at the same time, and so the physical and occupational therapists are often meeting and sort of planning, either overtly talking with people with ALS or sort of laying the plans in the background for, how frequently they're going to need to be seen, and sort of thinking about some of the big interventions that may be helpful down the line. And in research, physical and occupational therapists are adding to our understanding of what kind of stretching can keep people pain-free, and what kind of exercise regimens will keep people walking and active for longer. How do we prevent falls? How do we monitor strength in clinical trials? And even how do we quantify strength and behavior using digital devices? Speech therapists, sometimes called speech pathologists, are really focusing on two things, speaking and swallowing. But they also are, in many clinics, thinking a lot about weight, because swallowing and weight are so closely tied. So they can do a bedside swallow examination where they have people eat and drink just in the room, just to get a sense of how they're doing, and that can be very informative. There's also a test called the modified barium swallow, which is essentially having people eat or drink under a live x-ray so that we can see what's happening in the back of the throat and how safe that swallow is. And we're even developing quantitative speech analysis so that we can detect speech changes earlier and get them to see someone who's doing augmentative communication, like John Costello, who's going to speak later today. Some of the interventions, some of the sort of basic interventions, are about safe swallowing and swallowing twice, or chin tuck maneuvers, and so forth. And then also saving energy by doing things like using a voice amplifier so that people can speak more effectively throughout the day, and maintaining weight that keeps coming up again and again as something that we know is important. The planning phase for this is, do people want a feeding tube, and what's the right timing for that, and will it be required, and how do we sort of think about that over time? And also, I think, a more comprehensive augmentative communication evaluation, and when is that the right time to intervene. From a research perspective, I think a lot of research is going into weight maintenance, but using cough to understand whether people can protect their airway, that is, keep things from going into the windpipe. The effect of augmentative communication, the development of new augmentative communication, these are all things that speech pathologists are really sort of adding their heft to in ALS research. Respiratory therapists focus on one thing, really, and that is shortness of breath. But the characteristics of that can define what we need to do about it. So is it happening at rest, or just with exercise, or when people are lying down? And we can follow quantitative tests like vital capacity, which is when we have people breathe into a machine and get a number that we report back, usually as a % of normal. And there are some other tests that we can do, like maximum inspiratory pressure, where instead of having people breathe out, we have them breathe in as hard as they can. Interventions have to do with simple things like elevating a head of a bed if lying flat is hard. But there may be a time where people need BiPAP, and then adjusting the BiPAP if that's difficult to tolerate or isn't giving as much assistance as we need. And there's another machine called a cough assist machine that can help clear the lungs, clear saliva or mucus from the lungs. And again, when they're planning, they're thinking about when is a BiPAP required, and also how do we broach conversations about tracheostomy and ventilator. In research, this is a really important part of what we do. Strengthening exercises for breathing, there's long been question about whether that's a good idea, and there are studies going on around the country looking at that now. What's the best timing of BiPAP? How do we make BiPAP more comfortable for people who have a hard time using it? How do we use the cough assist most effectively? And what are the drivers of respiratory decline, and how can we intervene on those? And then finally, what is the role of vital capacity in clinical trials? This is clearly a very important part of the disease, and how can we capture that so that if we have a medication that improves respiration and breathing, that we can identify that. And the last group I want to talk about in the multidisciplinary center are the research nurses and coordinators, and just highlight why this is so important. Because in a disease like ALS, care and research are really two sides of the coin, and they merge in the multidisciplinary clinic. So at this point, we have more trials than ever in ALS. We have targeted approaches so that some therapies would be appropriate for only certain subcategories of patients. And we have entirely new methods for clinical trials. These are all incredibly exciting developments, but they make for a very complicated landscape. Whereas 5 or 10 years ago, we may have had one trial going on at a time, and we simply said, here's our trial, Do you fit or do you not fit? Would you like to be involved? Now we have 8 or 10 trials going on at the same time, and not everybody fits for all of those. And so that complexity has made it more important than ever that we match people with ALS to the appropriate research opportunities. And clinic is really one of the key times to make those matches, or at least begin that process. So we now have Judy Carey as a part of our multidisciplinary team. She's our research access nurse. She will often meet people in the clinic, but then spend a lot of time between clinics communicating with people with ALS to get them to the right opportunities. And that's been, I think, transformative in getting people involved in research when they want to be. We've been thinking a lot about how we help people maximize their benefit in ALS clinic. We've been putting together a welcome packet for our clinic to try to do this, and we had a very complex scheme to do this. And then we took a step back and said, you know, if we really want to get a message with 3 points across, that's about all I can remember. It's about what most of us can remember. Those 3 points are really, I think, write down your questions. You come in with questions. They'll be different depending on the visit. Write those down, and then spend a little time planning out your visit. It's a long visit. What are your priorities and what you want to talk about? Which are the most important questions? Who are the people that you want to be sure that you see? And sort of, you know, how would you like that visit to go? And the more that you think that through and have your questions ready, I think the better you do. And then because we're in Boston, and because we see a lot of people just coming, you know, sort of pulling out their hair because they're driving into Boston, and that's a harrowing experience, we just say, leave yourself plenty of time, and then it takes away the stress of sort of being late. Of course, we'll see if you're late, but it's just a stressful day. So that made the top 3, actually. The other thing that I think is really important is to stay connected after your visit, and I mean connected with the Multidisciplinary Center, but I also mean with the community. So organizations like Muscular Dystrophy Association can provide a community that sort of extends the group of people that you're connected with, and we think that's really, really important. And so one of the parts of our developing welcome packet is to sort of just provide you know, solid resources out there that people can connect to. I think it would be a mistake to talk about multidisciplinary clinics without talking about the emergency department. We work very hard to try to keep people out of the emergency department, and over the years we've set up urgent clinic visits that are staffed by nurse practitioners. We have video televisits. We've developed a house call program. I'll talk about both of those in just a minute. And we have a supportive neurology and palliative care arm in our clinic as well. And the idea here is to try to prepare for things before they happen, or be able to respond before they become sort of a true emergency, to try to keep people out of the emergency room. At the same time, most people with ALS do eventually have to visit the emergency room. And so we try to sort of plan ahead to get some indication in the notes about sort of where people are, where their heads are, where they're thinking about things, and where they are in their disease, so that when they show up to the emergency room, that information may be available to the emergency room physicians. We're also available 24/7 and frequently speak with emergency room physicians. The reasons that people go to the emergency room, I would like to say that I pulled this from a vast literature, but that's not true, because there is no literature about this. But I did spend a long time talking with both emergency room physicians as well as ALS physicians about this. And the things that we see taking people to the emergency rooms are frequently falls, sometimes constipation, which if we get behind on can be a real problem, urinary tract infections, pain and spasticity, and that's why we try to focus on that during our clinics as well, difficulty swallowing, a change in difficulty swallowing typically, shortness of breath, which may be from ALS, but it might be from an infection, either a viral infection or a pneumonia, and then care arrangements at home that are just not working. And I think that's another really important part of the multidisciplinary clinic, is to sort of use that as a time to check in on what you're doing at home and where you need more support, both for people with ALS as well as for caregivers of people with ALS. The last thing I'll say about our current multidisciplinary clinics is that our multidisciplinary clinics in ALS are set up in a way that is fundamentally different than our payer system. So our insurance system is set up for your routine physical with your primary care or an urgent care visit, where you go in and you see a nurse practitioner or a physician. You're with them for 15 or 20 minutes, and then you leave. Our visits are quite different. You're seeing 3 or 5 or 7 different people, and that is a whole different setup. We're still only reimbursed for one part of that. And so every time we see people, we sort of have a deficit. And it's organizations like Muscular Dystrophy Association and other organizations that help support multidisciplinary clinics and make that possible, and also philanthropic support to many of the clinics around the country. So that's a thank you to the Muscular Dystrophy Association. We want to go beyond what we do now, bringing innovative care to people with ALS. I think what we do has really proven to be a better care model than what we had in the past, but I now think that we have tools to advance this even further. And one of the first things that we can do, I think, is work on improving medical communication. And there are many, many aspects of this. So anytime that you've gone to a new clinic and had to get your records to that clinic, I think you probably then would see one of the breakdowns in our medical communication, which is from institution to institution. And there are privacy laws that make that difficult, but there are also not systems that make it possible. But I think that's beginning to change, and I think we can be drivers of that change, because it's really important in having comprehensive care for a serious illness like this, that we be able to communicate across institutions. We also spend a lot of time within multidisciplinary clinics trying to communicate with one another across disciplines, so that we can have sort of a holistic view of our patients. And I think that's critically important as well. And how we carve out and create the opportunity to do that is really important. And then how we communicate between providers and patients about specific issues is also changing. And I'll come to that more in just a moment. But I think in a time where we're used to having constant communication, not just with family and friends, but also with stores that are selling us things that are open 24 hours and brands that we can write back and say our shoes are falling apart and we demand a refund right now. And that actually really helps, and I think we value that, and I think we need to find a way to bring that to medical care, and I think this kind of care is the right place to do that, and we're beginning to work on how we set that up. And the last thing I would say is, in a general way, how do we communicate from a multidisciplinary clinic out to our patients? And one of the ways that we've tried to do this is have an email list that's available to sign up for on our website, and I think many clinics are beginning to do this so that we can message things out quickly. And one of the times that I saw the most importance for this was when Edaravone was first approved, and we needed to tell everybody in our clinic very, very quickly about this new development and get messages out to them quickly. And so I really have come to value that form of communication as well. We've also begun to rethink our sort of accessibility for clinic visits. And some of this I've mentioned, but we put in place urgent care visits with nurse practitioners, as well as telemedicine and a house call program. And I hope that is bringing care beyond just the walls of our clinic, beyond what people can come in and see us for at a routine every 3-month visit. And I hope that we'll see better outcomes and less emergency room visits. I think we're also at a place where we can begin to gather more data and better data to inform us better about how people with ALS are doing. And we can do this through digital monitoring. I'll tell you a little bit about that at the very end of the talk in a few moments. And also by developing good surveys and patient-reported outcomes that can flow to us in real time, so that we know not 3 months later, but at the time of an event, when somebody falls, when somebody has an illness, so we can help in real time. I think we're also finding better ways to support quality of life through symptom management, and also through programs like the Parenting for People with ALS, the ALS Parenting at a Challenging Time program. And Cindy Moore and Archana Basu will talk about this later today. But this is the kind of program that I think supports people with ALS in all of their, in all of their roles in life, not just as a patient, but as a person. And it's one of the most exciting programs I can think of in our clinic now. And finally, I think we see a big role as providing hope. And that, much of that comes down to finding ways to do things better, finding better ways to have clinic, but also finding a cure for this disease. And that's why we think so deeply about how we integrate research into our care and how we connect people with research opportunities if they'd like to be involved. So I want to talk a little bit about telemedicine for people with ALS. And I think of this as moving our care beyond the walls of our clinic. I think ALS is uniquely suited for this kind of care, because what we really do to care for people with ALS is ask about symptoms. and challenges that people are having and problems that they need solutions for. And that conversation then brings us to the ability to propose new solutions, whether that's a new medication or new equipment. It doesn't rely much on the physical exam. You know, if somebody tells me that their hand is weaker and they're having a hard time opening their door, well, then we need to work on that problem, regardless of whether my exam shows that their hand is weaker or not. And so we can do this from afar. So we deploy these solutions, and then we sort of have to circle back and assess whether they're working. And I think telemedicine gives us an opportunity to do that more quickly and therefore more effectively. So we can either revisit our solution or move on to the next problem and try to solve that. At MGH, we've been working on this since about 2011, when we sort of repurposed a program that was being used to communicate from one hospital institution to another hospital institution. And we expanded that to sort of caring for people in their homes. And it was fraught with, really with obstacles, though one might not think so. There were legal challenges where we were not covered from an insurance perspective to see people who are out of state. Why you can have a phone conversation with somebody but not a video phone conversation with somebody is sort of beyond me, but that still remains true in some states. We've been able to work through some of those things. So even things that seem simple can sometimes in the medical field have bigger implications. We have worked through those. There are a few practicalities tied to our program as a result of them. So people with ALS must first be seen in person in our clinic. We can't diagnose or give a second opinion without first seeing people in our clinic. And I think that's reasonable. So we use this for follow-up care. And then the second part of this is that people with ALS have to agree to be a part of a telemedicine visit. And I think this is important because another potential pitfall for a program like this is that people want to be seen in person and can't get the opportunity. And that's really not how we position this program at all. Now, we looked back at a 16-month period from 2014 to 2016 to try to get a sense of who we were seeing and what the population was like and who are we serving with this program. And what we saw was that we'd done about 140 televisits over that time at a rate of about 9 a month. We're between double and triple that now, so our program has really grown. But the patients that we saw then and the ones that we're seeing now are very similar. About half of them are ambulatory, about a third are using BiPAP or have a feeding tube. And then there's about 20% that have a tracheostomy. So we're seeing people really across the spectrum of the disease. I think I anticipated it would be people who are mostly later in the disease. It actually really spans the disease. And then I think, anticipated that we would see heavily people were visiting us by televisit from far away. But it turns out on this map, each of these concentric circles is one quintile, 20% of the people. So the first, second, and third quintiles, that is 60% of our population in telemedicine, are from New England. And it's not until we get to the last 20% that they're from really across the country. And I was surprised by that, but perhaps I shouldn't have been, because I think this is a really useful way to see people. We then asked the question, how medically useful are these televisits? We wanted to get away from how satisfied are you, because I always give the example of sort of, let's say you took a group of people and gave them colonoscopies, and took another group of people and didn't give them colonoscopies and said, okay, well, how satisfied are you with your care? We can bet that the ones who didn't have the colonoscopies might be more satisfied, but that doesn't make it better care. So, we hope that a multidisciplinary visit isn't quite like that, but you see the point. What we really tried to get at in these questionnaires that we designed was we gave a series of sort of scenarios and asked, how well can we accomplish the goals of this visit based on a televisit or an in-person visit? And we did this with people who had both televisits and in-person visits, and we did it with providers who were doing both. And remarkably, both providers and patients kind of said across the board in a very, very high-level way that medical video televisits are about 75% as useful as in-person visits. There are just some things you can't do when you're not in the clinic. And that number helped us because we said, actually, wow, that's pretty high, higher than we would have guessed, actually. But also, it allowed us to do an adjusted cost analysis. And I think this is important because we need to convince insurance companies and the government that televisits are useful and should be paid for. And one of the ways to do that is to show that they cost institutions and patients less. And so we did an exhaustive analysis of all the costs that go into visiting a multidisciplinary care center, and also putting on a multidisciplinary care center, salaries and room spaces. And for patients, it's travel, and it's travel of a caregiver many times, and it's finding childcare, and it's missing work, and the people that you're traveling with missing work. And so we did a very exhaustive sort of analysis, and we found that it can cost up to $1,200 for people with ALS to come to an in-clinic visit, and only about $120 for a televisit, because it's shorter, because they're at home, because other people don't have to take off work. And it's cheaper for the institution as well. We'll soon have this published, and I hope that this will be a way that we can start to encourage more insurers to cover these televisits. The last thing I'd say about telemedicine is that really our journey has just begun. In the 20th century, we really centered care at hospitals. And the reason for that is that new technology dictated that. I'll show you a picture of that in just a minute. But in the 21st century, we have new technology that really, I think, can allow us to decentralize our care and sort of remotely monitor people so that we're not bringing them in to do some of the monitoring that we do now. I think we'll look back in the future and say, oh, we used to go to the clinic for that, but we don't need to do that anymore at all. And we're just scraping the surface now. So things like vital capacity will become very easy to do at home, and we already have web-connected scales so we can keep an eye on people's weight. But virtual reality is also coming, so that we'll be able to feel like we're in a room with the person that we're talking to, and it'll begin to really change, I think, the way that we think about telemedicine. At the same time that we're taking this very high-tech route to breaking down barriers to care, we're also taking sort of a step back, I think, but in a very calculated way, and we've developed an ALS house call program. One of the first patients that I saw in a clinical research study when I was a medical student, not for ALS, but for a pain study, gave me an old newspaper. And the newspaper article was called "What Duty Does a Physician Owe to the Public?" And this actually hangs in my house to this day. It's from 1897. And it's really about how do we most effectively use the resources we have to care for people in a way that is most compassionate to them. And I think that those principles still underlie what we do today. This was from a time where house calls were really the way that medicine was carried out. This is where I work. This is Mass General Hospital. It's very different. And it's different because we have things like CT scanners and MRI scanners and operating rooms and ICUs. And we need to bring people to a high-tech center to give that kind of care. But for somebody who's coming to that center to get multidisciplinary care for ALS, which is largely not dependent on high-tech machines, it can leave us saying, what about me? We put you at the center of the multidisciplinary clinic and center that multidisciplinary clinic at this very high-tech center, and people have to come a very long way to see us. And I think really what this highlights is that the time is right for a return to house calls. And it's not just ALS, it's not just me, but actually there are lots and lots of programs that are beginning to sort of open their doors for house calls as well. And I think this is also not the house call of yesteryear, because we have cell phones and electronic medical records and GPS and video televisits that allow us to stay connected. And the point of this house call program is to really bring our expertise from the ALS Center, multidisciplinary care, to the person's home. It's very much a pilot project. But in year one, we've done 393 visits, almost 400 visits. We're doing this in conjunction with Compassionate Care ALS. We've done visits together for 201 of these, and they've done another 450 visits on their own. So we've seen people in 850 visits. We're going to 9 out of the 14 counties in Massachusetts, and almost 40 of these people have Mass Health or Medicaid. Typically, this would not cover something like a house call, but because this is supported by a donor-supported grant, we've been able to sort of see people regardless of coverage. The feedback on this house call program has been remarkably positive, more positive than I would have expected, and in fact, people are saying that they like it better than coming to clinic, which is, again, I think it falls into the ecosystem of how we care for people. I don't think we envision this as taking the place of a multidisciplinary clinic, but providing another way to care for people and really updating our thought about how we care for people for the next century. Along with all of this care, we need to have a new stream of information to understand what's happening with people with ALS. And that is something that we call digital phenotyping or mobile health or health technology or quantitative medicine. We have not decided on a good name for this, and it's a bit of a problem. But it's essentially using an app or a device to kind of get a steady stream of information, either subjectively from what people with ALS are saying or objectively from sensors that are telling us about how they're doing. So we've done a pilot study using a cell phone app, and we were able to ask people at home about their ALS functional rating scale. And for those of you who don't know about the ALS functional rating scale, it's a commonly employed questionnaire. It has 12 items. Each one of them are scored 0 to 4. And it was designed to be given in the clinic, delivered by a trained person to sort of extract the answers. But we've begun letting people answer these questions on their own, and nobody had really compared whether the answers we get when people answer it on their own are the same as when we ask it in clinic. But we were able to do that on cell phones. It turns out there's a very, very high correlation, probably within the error of the questions. And so, I think that's a valid way to get information, and I think it can tell us about how people are doing. We also would like to develop new ways of asking questions that are even more relevant to people's lives. And there's a group in Rochester, New York that's working hard now on a new patient-reported outcome that I think is exciting. We also had the ability to record passages from the phone and then work with speech pathologists to do a quantitative analysis of those. And this is the first pass of that analysis, and it's just looking at pause time. So in that recording, from when people start speaking to when they stop speaking, how much of that is pause? Because one of the things that we do to maintain intelligibility if we have any difficulty forming words or articulating is to slow our speech and pause more between words. And so we can see that over time, pauses are increasing. What's interesting is that many of the people in this study had no changes on the ALS functional rating scale as far as their speaking. So they would say that they were speaking fine, but we can already detect some change. That can be very powerful for clinical trials and allow us to do a clinical trial more efficiently with fewer people over a shorter period of time. So I'm excited that this may be an outcome measure as well as telling us about what's going on clinically and when they might need to visit somebody for augmentative communication. Finally, we had the ability to follow GPS, not unlike Google Maps or Apple or weather.com or many of the other apps that are following us around on our phone. We were able to see how far people were traveling. And what we found is that in people who were walking well at baseline, they were either walking independently or mostly independently. We saw that they, over time, traveled less distance per day. Now, this is not just how far they're walking, it's how far they're going in a car, how far they're going on a plane. It's just on average, if we follow that dot of their cell phone around, how far is it going? So it's remarkable that we can see such a high-level behavioral change over that period of time. And again, there may be some value in both clinical work as well as in clinical trials. And we also see that time spent at home increases. Now, one of the really important things about this kind of technology is that it can start to answer a question that regulatory agencies ask. And we've seen them ask this about edaravone. They say, okay, it slows the disease, but does it impact people's experience with the disease? And if we had this kind of data, we would be able to say, yes, people are getting out of the house more, they're traveling more, we are quantifiably, we are impacting their disease. And it takes away really any barrier to insurance companies paying for some of these treatments. So I would close this part of the conversation by saying I think it's time to embrace digital healthcare. There are many reasons that we don't do this, but there are lots and lots of reasons that it can actually, done correctly, bring us closer together as physicians and people with ALS and caregivers of people with ALS. So I think there is a bright future. I think there are really exciting new directions that we're taking in care. Many of them also apply to the research that we're doing. And I'm going to stop here and thank MDA again for the support that they give our clinic, as well as many clinics and many patients around the country. The EGL Foundation has supported our house call program, as well as the Parenting at a Challenging Time for People with ALS program, and many other funders who have funded projects that we're doing and care that we can give at our center. I'm going to take a moment to, I don't know if we have a minute for any questions. Why don't we take a minute for questions, and then I can introduce our next speaker, will be Bob Brown.
Yeah, thank you very much for your presentation. I have a question about the telemedicine between your center downtown with the difficult access and parking and all that, and other MGH-affiliated centers around the Boston area. Do you combine multidisciplinary ALS with those centers so that somebody could go to a center close to them rather than come down there?
Yeah, that's a really good question. That is not something that we've rolled out yet, although it's something that we've talked about, and there are some complexities we have to work through to sort of figure out how that would work. One of the things that we actually have talked about is having a multidisciplinary clinic at one of the MGH affiliated centers that's outside of the city, Waltham or down south, for exactly that reason. Center to center telemedicine like that is absolutely possible, and it's something that we have looked into, but I think it'll be maybe a next step. But I really appreciate your question. I think it really helps me think about what are our next priorities. Yeah, sure. Again, it's so important to hear, and I think we feel that, and I'm really hopeful that we've got a better tool here. We need to do some more work with it, but there are other groups who are working on this quantitative voice analysis as well, and it's looking very promising.